Now, in the second section of our lecture, we will discuss about the pathogenesis and pathology of Entamoeba histolytica, and also the clinical syndromes caused by the Entamoeba histolytica pathogenicity and complications associated with Entamoeba histolytica infection. So pathogenesis and pathology. Ology is the study of, patho is the abnormality or disease. So we will discuss how the disease process associated with Entamoeba histolytica, how it develops and how it presents itself. Both trophozoites and cysts found in intestinal lumen. In the first section, we went over the life cycle and the transmission of Entamoeba histolytica, and we know that the cysts are released in the feces and then they are ingested, and the cysts then go into the intestine, cause invasive disease of the intestine, and then later on colonization can occur in the liver and the lungs, and cystation of the cyst occur in the intestine, and then those cysts grow into the trophozoid form, and then those trophozoid again form cyst and released in the fecal matter. So this is a life cycle. We can see this cycle goes in a circle and released from the human, goes in the human by the oral route. So both trophozoites and the cyst form of Entamoeba are found in the intestinal lumen. Trophozoites of Entamoeba histolytica invade the tissue. We know that Entamoeba histolytica cause invasive disease, produce the invasive disease, more virulent, cause invasion of the tissue, and as compared to Entamoeba dispar, which produce mainly asymptomatic illness. Trophozoid of Entamoeba histolytica, they are about 20 to 60 micrometer in diameter, small, contains vacuoles, nucleus with a characteristic central nucleolus. So they have a vacuole and they have a nucleus with characteristic central nucleolus. Pathogenesis and pathology, again, what happens is depletion of intestinal mucus, diffuse inflammation, and disruption of epithelial barrier. So as the invasion of the tissue, as the invasion of intestinal tissue takes place, then there is depletion of intestinal mucus, diffuse inflammation takes place, and there is disruption of epithelial barrier. And once there is disruption of epithelial barrier, the infection can spread and cause serious illness. Precede a trophozoid contact with colonic mucosa. So all these changes occur before the trophozoid come in contact with the colonic mucosa. Trophozoids attach to colonic mucus and epithelial cell by their GalNAc lectin. So the GalNAc lectin is present in the trophozoid by which they are attached to the mucus and epithelial layer. Earliest intestinal lesions are micro-ulcerations of mucosa of cecum, sigmoid colon, or rectum. So earliest intestinal lesions are microulceration of mucosa of cecum, sigmoid colon or rectum. So ulcers are produced on these, you can see on the cecum, sigmoid colon or rectum. Release erythrocytes, inflammatory cells, and epithelial cells. So it's a very, very clear picture and presentation of pathogenesis of Entamoeba histolytica disease. What happens is there is, because they are invasive, they can cause invasion of the epithelial lining, cause disruption of the epithelial lining. Once there is disruption, then there is attachment or contact of the trophozoite with the mucus and epithelial cells, and there is formation of ulceration in the sigmoid colon, cecum and the rectum, and then there is release of erythrocytes and inflammatory cells, and then all this inflammatory reaction takes place. So very, very clear picture how that develops. Proctoscopy. Procto is for the rectum. Scopy is examination. So the examination of the rectum with the help of proctoscope. Proctoscope is the instrument that is used for the examination of the rectum. So what happens, what we see on the rectum examination, there are small ulcers with heaped up margins. So small ulcers are present with the heaping up of margins. Normal intervening mucosa. Classic flask-shaped ulcer. Flask-shaped ulcers are characteristic of Entamoeba histolytica infection. So there are flask-shaped ulcers containing trophozoites at margins of dead and viable tissue. Neutrophilic infiltrates may accompany early lesions in animals. Human intestinal infection is marked by paucity of inflammatory cells. Treated ulcers heal with little or no scarring. Occasionally, full thickness necrosis and perforation occurs. Next is amebioma. What is amebioma? It's the rarely intestinal infection. What happens? It results in a mass formation or amebioma, which is present in the lumen of the bowel. So amebioma, you can see it's the mass developed in the intestinal lumen. Overlying mucosa is thin and ulcerated. So mucosa that is overlying the amebioma, oma is the tumor or the growth. So overlying mucosa is thin and ulcerated. Other layers of wall are thickened, edematous and hemorrhagic. So all the overlying mucosa is thin and ulcerated, but other layers of the wall, they are not thin, they are thick, edematous and hemorrhagic. Exuberant formation of granulation tissue with little fibrous tissue response. Next, proteases from Entamoeba histolytica as virulence factor. We already mentioned they have virulent factor present. So what is that virulent factor is the proteases which are released from the Entamoeba histolytica, which act as a virulent factor that causes invasion of the tissue and cause disease. So we have the proteases, these are the plasma cells. From the plasma cells, we have immunoglobulin A, then we have Entamoeba histolytica, proteases released, then we have neutrophils. All these are different inflammatory cells present. They can cause the invasion of the tissue, breaking of the tight junctions which are present in between of the epithelial cells. Once there is breakage of the junction between the epithelial cells, you can see all these inflammatory processes or cells enter into the epithelial cells, and they can reach the extracellular matrix. So they affect the mucus layer, cause the disruption of the epithelial cells, breaks the tight junction between the epithelial cells, and can access the extracellular matrix. The different type of substances which are present is, we can say these are the fibronectin. We have fibronectins, these greenish. Then we have collagen, fibronectin, collagen, laminin 1 here, these are the laminin, lactoferrin from neutrophils, these are the lactoferrin from neutrophils, these are the lactoferrin produced from the neutrophils, which are the white blood cells. Then we have lactoferrin from exocrine glands, these red ones here. Then we have secretory immunoglobulin IgA. These are secretory IgA. Interleukin IB, interleukin I8, intestinal, these are the intestinal microbiota. So these are intestinal microbiota. So that's how the proteases which are released from the Entamoeba histolytica proteases, they can cause the inflammatory reaction, cause disruption of the tight junctions between the epithelial cells, and cause reach the extracellular matrix, and then the whole process of or whole pathogenesis of Entamoeba histolytica can progress. Amebic liver abscess, we already mentioned colonization of Entamoeba histolytica. It cause invasive intestinal disease, and it can cause colonization in the liver and the lungs. In the liver, it can cause abscess formation known as amebic liver abscess. So we have from the feces cysts passed, these cysts again ingestion, we know this life cycle already. They can cause encystation in the small intestine, large intestine, and also goes into the liver. Colonization in the liver cause amebic liver abscess, formation of abscess in the liver associated with right upper quadrant pain, tenderness, fever as a result of amebic liver abscess. Immune response to Amebiasis, we can see again there is Entamoeba histolytica, release proteases. We already went in detail over the proteases. Glycosidases are released. These can cause mucin and extracellular matrix degradation. and they also cause phagocytosis and trogocytosis in the intestinal lumen. Mucin layer is attacked, and then they can release all these in the epithelium: interleukin, beta 6, 8, 12, internuclear factor, intestinal necrosis factor, gamma, tumor necrosis factor. All these are released, and they can start an immune response to amebiasis, and extraintestinal can go into the matrix and the liver. So the main process of Entamoeba histolytica pathogenesis is by the proteases. These proteases cause different chemicals to release, and they act on the intestinal epithelial layer and cause the breakage of tight bonds, cause release of different inflammatory substances, which in turn cause different inflammatory responses. Intestinal amebiasis, most common type of infection, asymptomatic cyst passage. Even in highly endemic areas, most patients harbor Entamoeba dispar. So intestinal amebiasis is usually asymptomatic because we already mentioned in these cases we have Entamoeba dispar, and this infection is non-invasive and non-symptomatic. Symptomatic amebic colitis develop 2 to 6 weeks after ingestion of Entamoeba histolytica cyst. So it takes about 2 to 6 weeks incubation period. A gradual onset of lower abdominal pain, diarrhea, malaise, weight loss, diffuse lower abdominal or back pain, cecal involvement, mimic acute appendicitis. Amebic dysentery is a condition, one of few conditions that present with fever with chills. So in this case, we have fever with this chills like UTI, like malaria. So it mimic acute appendicitis when cecum is involved. Full-blown dysentery past 10 to 12 stools per day, contain little fecal material and contain blood and mucus. Heme-positive stools are present in amebic dysentery. Predominantly in children, more fulminant intestinal infection with severe pain, fever, and diarrhea. Toxic megacolon, enlargement of the colon occurs, severe dilatation with intramural air. Patients receiving glucocorticoids are at risk because their immune system is affected. Chronic form of amebic colitis confused with inflammatory bowel disease. A positive serologic test or biopsy. Now, amebic liver abscess, extraintestinal infection, most often involves the liver. You can see that's the abscess present in the liver. Young patients more likely present in the acute phase with prominent symptoms of less than 10 days. Clinical presentation is febrile fever, right upper quadrant pain where liver is located, dull or pleuritic in nature, may radiate to shoulder, point tenderness over liver is present. So these are very, very important clinical presentations we find on the examination of the liver. Right-sided pleural effusion due to spread of infection to the lungs, pleural effusion is present. Jaundice can also develop. Complications of amebic liver abscess, pleuropulmonary involvement in 20 to 30% patient. Most frequent complication of amebic liver abscess is pleuropulmonary involvement. Manifestations, sterile effusions, contagious spread from liver, rupture into pleural space. Treatment, sterile effusions and contagious spread resolved with medical therapy. Frank rupture into pleural space require drainage. Hepatobronchial fistula cause cough, production of large amount of necrotic material. So fistula is the connection between two structures. As a result of the abscess formation, and when it spreads to the lungs, there is chances that we form hepatobronchial fistula. In that case, there is cough, production of large amount of necrotic material, may contain amoebas. Abscesses that rupture into peritoneum. Peritoneum is the lining of the abdomen, and abdominal structures are present in the peritoneal covering. Present as indolent leak or an acute abdomen. Require both percutaneous catheter drainage and medical therapy. Rupture into pericardium, layer covering the heart, usually from abscess or left lobe of the liver, carries the gravest prognosis. It can occur during medical therapy. Requires surgical drainage. So all these are different complications, mainly involves the spread to the lungs and to the heart or to the peritoneum, and we need to drain and treat medically. Other extra-intestinal sites, genitourinary tract, involved by direct extension of amebiasis from the colon or hematogenous spread of infection. Painful genital ulcers characterized by punched out appearance and profuse discharge may develop secondary to extension from either intestine or liver. Cerebral involvement, fewer than 0.1% cases. Symptoms and prognosis depend on the size and location of the lesion. So you see, we have so many different organs involved by the Entamoeba Histolytica because of its invasive nature, begins in intestine, spread to the liver, cause the abscess, cause through the spread through to the peritoneum, lungs, also to the pericardium and the other organs which can be affected. We have genitourinary tract. It can also form genital ulcers, and cerebral involvement also very, very limited, 0.1%, but it can cause involvement of the cerebrum. So that concludes our section 2. Thank you for watching sqadia.com.